You don't have to know everything, just where to ask, especially in a complex multidisciplinary field like head and neck cancer. On Primum, fellows and oncologists get fast one-on-one answers from experienced oncology specialists, helping you show up prepared and confident. And it's completely free. Sign up today at primum.co.
Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the HEMONC podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we kick off another series, this time moving on to solid oncology and specifically talking about head and neck cancer.
Really excited to kick off this series. It's been a while since we all got back together to record. We've all been busy doing some other things. Life has happened. We now can tell all of our listeners we're back on a normal schedule. We'll get these episodes out to you guys. Excited to get back into solid tumor. It's been a second.
Yeah, and I think this is an important topic. It's one of these things, highly curable cancer, but treatment is pretty morbid. And so figuring out ways to de-escalate, there's a lot of new directions in this field. So I'm excited to get into it too.
And I feel like we don't talk about this disease enough. And so hopefully we can help clarify how our listeners should be thinking about their approach and more importantly, talk to their patients about treatment options. So guys, I'm really excited for this series. So without further ado, let's roll that show. Guys, we are about to record another series, but I think the thing that is certainly on all of our minds, it's everything World Cup right now. How are we feeling? What are your thoughts? Some of these games have been insane.
I think the Mexico-England game was honestly the most nervous I've been in a very long time. It was such a good game. Good for England for doing that. Hopefully they don't choke later. For our English listeners, I'm sorry, but it happens. We'll find out. By the time of this recording, the game will have already passed for the next stage here, but we'll see what happens.
Yeah, it is something of a tradition at this point. I won't say anything more to avoid losing some English listeners. But yeah, I'm hopeful that they buck that trend this time. It's been some great games, though. Argentina and Egypt, that was a classic. There's just been some great Paraguay. Incredible. Yeah, some great games.
Regardless of what had happened with our US team, I think just the way that everybody has rallied around this team has been really cool. And I will say, living in one of the host cities, it's been incredible to see the energy in our city with visitors and people checking out the FIFA Fan Festival. Just a really, really cool time to be in one of these cities. Riding this excitement then into our next series, I'm excited to talk about head and neck cancer today. And I think in usual fashion, why don't we kick it off with a case?
Let's meet our patient. We got a 61-year-old guy. He's presenting to his primary care doctor with a lump on the right side of his neck that he noticed about 6 weeks ago while he was shaving. It's painless, hasn't changed much, and he otherwise feels well. He does have a 15-pack year smoking history, but he quit 10 years ago. He drinks socially and has no fevers, night sweats, or weight loss. On exam, there's a firm 2.5 centimeter mobile node on the right neck just below the angle of the jaw. The rest of the head and neck exam is unremarkable. He started on a course of antibiotics for presumed reactive adenopathy. Maybe he's got a tooth that's swollen or something like that. But the node is still there at the 4-week recheck. So before we get further into this case, let's just cover some of the basics. Again, I think we all know where this is headed, right? This is a head and neck cancer episode. This isn't an odontogenic infection episode. So most of the time, when we're talking about cancer, it's in association with a specific organ like pancreas or colon. So what is head and neck cancer? Why do we call it that?
Head and neck cancer is an umbrella term for cancers of the oral cavity, oropharynx, larynx, hypopharynx, nasopharynx, and the sinonasal tract. So you can see anatomically, it covers a large portion of the neck upward. And so this is a thing that always confused me in fellowship. And the most important thing is that you take a look at some diagrams. We'll attach them to our show notes when we think about head and neck anatomy. So each of these locations matter. And I think that's the biggest thing in head and neck cancer, that the location, the site of the cancer changes and dictates our treatment decisions. The overwhelming majority, more than 90%, arise from squamous cell carcinomas, and that's coming from the mucosal lining. It's historically been a disease of older men with a strong male predominance, and that male skew persists today. The single most important framing that I think about for the series, particularly for this whole series, is that we essentially have two biologically distinct diseases that happen to live in the same anatomic neighborhood. The first is the classic carcinogen-driven cancer. And this is why when we take a social history for our patients, we really care about tobacco and alcohol use, whether that's chewing tobacco, smoking cigarettes. These are really high risk factors for developing a head and neck cancer anywhere in the tract that I described previously. The second is viral-associated cancers. And in particular, we're going to focus on HPV-associated oropharyngeal cancer. This is driven by high-risk human papillomavirus, classically located in the tonsil and the base of the tongue. These patients are often younger, frequently never or light smokers, particularly if they're in the oropharynx, have a better prognosis. The epidemiology has flipped over the last 2 decades. As smoking rates have fallen, tobacco-related head and neck cancers have also declined. But HPV-associated oropharyngeal cancers have rose sharply so that it now accounts for the majority of oropharyngeal cancers in the United States. And oropharyngeal cancer has overtaken cervical cancer as the most common HPV-driven cancer. This is why now we have vaccinations for the HPV. And that's really, really important when we think about younger patients for their primary care, that they're getting vaccinated. So why does this matter for our patient? Why are we going through this? Well, he does have a smoking history. He does have this painless neck node. And for a 61-year-old with a smoking history, has a node in their neck, we're very concerned that this could possibly be a type of malignancy, whether that's the head and neck cancers that we're talking about now or potentially a lymphoma. So these are the things that we think about in our differential.
So Vivek, I think that was a fantastic introduction to our conversation today. So much to unpack in what you just said. But, I think the first thing that I want to point out is that you mentioned tobacco and alcohol being one of the, or two rather, of the agents that we have to ask our patients about. What's special about this? Is it, if somebody does both, does that increase their risk? How does all that work?
Yeah, so it definitely increases risk. And the risk is not just additive, it's actually a synergistic effect. Some pretty groundbreaking epidemiologic work showed that heavy tobacco and heavy alcohol together is a significantly greater risk than just the sum of their parts, on the order of like a 30-fold increase of risk in the heaviest users. We think that partly what's happening here is alcohol is helping solubilize and enhance mucosal penetration of some of these tobacco-related carcinogens. And in addition to that, of course, the alcohol metabolite acetaldehyde is a carcinogen all on its own. We think that's probably the reason why it's such a dramatic increase in risk when they're combined together. This is also where we get that concept of what we call field cancerization, sort of weird term. But basically, back in 1953, Slaughter and colleagues came up with this idea that when the aerodigestive tract is exposed to these risk factors, this combination of alcohol and tobacco products, that whole field, that whole anatomic field is kind of bathed in the same carcinogens. And so it's all primed for tumor formation, which is why we see in head and neck cancer patients with these risk factors, there's a really high rate of second primary tumors, rates around a few % per year. And so that's why we kind of do the long-term surveillance that we do in these patients. Another sort of niche risk factor we wanted to call out was betel nut chewing. It's a major risk factor for oral cavity cancer in Southeast Asia. It's worth knowing if you have a large population in your practice from that region of the world. Something we don't get into as much in this series, but the nasopharynx, also an important site. And that's a different type of viral risk factor there. Epstein-Barr virus is the main driver there, with, again, a pretty striking geographic ethnic distribution in risk, primarily in southern China and Southeast Asia. But we won't get too much into that. Let's get back into some of the basic science here for just a minute. Can we talk a little bit about what high-risk human papillomavirus, high-risk HPV, is actually doing to these cells? And kind of how do we figure out that was what was driving these cancers?
This is a fascinating story, and it really takes place in the 90s and the early 2000s when Dr. Gilson and colleagues at Hopkins assembled the molecular and epidemiologic evidence that a subtype of oropharyngeal cancers were caused by HPV. And this is super important for our listeners to remember. The high-risk genotypes of HPV are HPV 16, 18, 33, and 35. So again, 16, 18, 33, and 35. And HPV 16 is responsible for the vast majority of HPV-associated oropharyngeal disease. Mechanistically, it comes down to two viral oncoproteins, E6 and E7. So E6 is the protein that promotes degradation of P53. And so, as you may know, P53 is important and known as the guardian of the genome. So if E6 promotes degradation, that allows sort of that unchecked growth. E7 binds and activates the RB protein, the retinoblastoma protein, releasing a protein called E2F and driving the cell through the cell cycle. So you can see how together this can be synergistic also in promoting the disease. So here's why any of this really matters. When that RB protein is knocked out by E7, the cell loses RB-mediated feedback suppression of a protein called P16. And so that's why P16 overexpression by IHC works as an inexpensive marker for transcriptionally active high-risk HPV in the oropharynx. And so how do we do this test? You can either do the IHC for P16, or you can use in situ hybridization or RNA-DNA testing for HPV. But it's really, really, really important that this is something that we do assess in our patients that may have concerns for this disease.
I think this is really important, and we have these viral oncoproteins that's driving our issue here. And this is driven by these high-risk HPV strains that Ronak had mentioned. Just remember the number 16. Always remember that in 16, you go to sex ed class. You probably should have been in sex ed class, or that's where it matters a lot. And think about HPV. That's something it can be. We think about sexually transmitted and things like that, that you remember at 16 years old. That's the HPV 16, P16. So if you remember something, just remember 16 when it comes to this kind of thing. So when we think about this, one of the things I want to highlight, P16 overexpression is a prognostic marker. We talked about how in oropharyngeal cancers, HPV-mediated oropharyngeal cancers have a better prognosis. This isn't always true in other anatomical areas. So a P16 positive larynx or oral cavity cancer doesn't have the same favorable biology as a P16 positive oropharyngeal cancer. This is why the anatomic location really, really matters. So when you see P16 positive on a path report, always anchor that to the primary site before you let it change your prognosis or staging. You still need to know the primary anatomic site. So even if you have one lymph node, you get a biopsy and say it's P16, that leads you to think this is very likely going to be an oropharyngeal primary cancer, but you need to confirm that. You need to find the anatomical location and remember that oropharyngeal P16 is the favorable prognosis, not necessarily in other regions.
Such a good reminder, Vivek, again. And so speaking of workup, right? So this gentleman has this lump that's in his neck. Can one of you guys go through what that workup would really entail? What are next steps here?
So at this point, it's really critical to start involving ENT, our ear, nose, and throat colleagues. They need to get involved for direct visualization, so direct exam with a flexible fiber optic exam of the entire upper air digestive tract. You really can't stage or treat what you find on a node biopsy until you've figured out what's going on, how many primaries are there, where they're located, all that. And you can't do that without the exam. That's step one. As far as working up that node itself, FNA is a great first step. It's low morbidity and it's usually diagnostic. This is in stark contrast to our lymphoma episode where we're saying with high suspicion for lymphoma, you got to get excisional. We need that architecture. In this case, we're pretty sure this is going to be a solid tumor. And FNA will at least get us that answer. Is it solid tumor? Is it lymphomatous? That's a great first step. Next up, we need some imaging workup. In addition to that direct visualization with ENT, we have to understand what burden of disease we're dealing with. How many nodes are involved? Is there involvement of the lungs? Typically, we could start with CT of the neck and CT of the chest, looking for synchronous lung primaries, distant disease, things like that. But oftentimes, we just go for a PET CT. It's more sensitive for nodal and distant disease, and it's especially useful in planning radiation fields when that nodal disease is present. And sometimes it can even help us identify an unknown primary. So oftentimes PET is kind of where we're jumping these days. A couple of supportive care steps that are really easy to forget but are super important, especially in patients headed towards radiation. You got to get a dental evaluation. You have to address any problematic teeth in the radiation field because that dramatically reduces the risk for osteoradionecrosis. That's something we'll get into in later episodes, but a super important upfront thing that you have to do before you can even start treatment. You also want to get a baseline swallow evaluation, often with a VFSS or a video fluoroscopic swallow study. Of course, counseling on smoking cessation is critical here as well. I feel like that's going to happen in a lot of our tobacco-associated cancers, but it's worth calling out. Head and neck cancer is complex, and the toughest decisions often require perspectives from medical oncology, radiation oncology, surgery, pathology, and supportive care. With Primum, fellows and oncologists can ask experienced oncology specialists directly about cases, emerging data, or career questions and get clear, thoughtful answers in hours. Ask anonymously or by name and tap into the experience of more than 140 oncology experts, one-on-one and completely free. Join today at premium.co.
Dan, I think that was really, really great. We start with an FNA. And so for our patient, the FNA comes back as a P16 positive squamous cell carcinoma. The ENT scope didn't show an obvious primary. So there wasn't a big lesion at the base of the tongue, nothing that they could have found that was an obvious primary. So how do we find the primary? We talked about how that's critically important. So just because you have a neck node that's involved with squamous cell carcinoma, you still need to find that primary. Dan had talked about the CT neck and chest. Sometimes, though, we just go ahead and get that PET CT. So, Ronak, in this case, our patient did get a PET CT. So can you tell us a little bit about the results of the PET CT and how that changed management for this patient?
Essentially, in this case right now, all we know is that we have a squamous cell carcinoma of unknown primary. We are suspicious based on that P16 positivity and that cervical node that this is likely to be oropharyngeal. But as we pointed out, we still need to identify what that primary source is, and we haven't yet accomplished that. In this case, the PET CT was actually negative. When it's positive, great, we may have our answer. But for the purposes of this conversation, the PET CT was negative. So what do we do next? The next step from here is to recommend doing an exam under anesthesia, an EUA. And this is, again, involving our ENT colleagues. They're going to go in, they're going to look very, very closely, and they're also going to take directed biopsies of the base of the tongue and the ipsilateral or bilateral tonsils, and actually quite frequently even just do a tonsillectomy. And this is because we are very suspicious that the primary is hiding in those tonsillar crypts. Again, why are we obsessing over this? And this is because the primary site really dictates staging and treatment. Because remember, as we've said so far, a P16 oropharyngeal primary is staged and treated and prognosticated very differently than, say, a laryngeal primary. And really finding the primary lets the radiation oncologist know, for when this patient needs treatment, what area to target rather than irradiating the entire mucosa, which can result in greater side effects and poorer patient outcomes. So it really, 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 really is important to identify exactly where the primary is.
And Ronak, that's important too, as we think about surgical management definitively versus radiation management. And sometimes you'll see, as we get through the series, you'll see some patients who are upfront surgical candidates, some patients who have more locally advanced disease will start with chemotherapy and radiation, and some patients get adjuvant radiation or adjuvant combined chemotherapy and radiation. By the end of the series, you'll totally clearly understand which patient falls into which category.
Thank you guys for going over that. We have talked about the neck nodes a fair amount here. This is something I always struggled with when I was in head and neck clinic. I remember frequently pulling up on my iPad like that anatomic diagram. Could one of you orient us to the cervical lymph node levels? You hear about level 2, level 4. What does that mean in terms of the sort of geography of the neck?
The way I think about this is that level 1 is higher up and level 6 is lower down. And so level 1, we're talking about submandibular, submental area, floor of mouth, oral cavity, lip area. And then we can go down to all the way down to level 6, which is the thyroid, subglottic larynx, and the cervical esophagus. The best way for our listeners to do this is look at the map. Us talking about this isn't going to help you as much. Look at the map, but just know that we're going from higher to lower. Level 1 is at the level of the submandibular area, and level 6 is lower down around that cervical esophagus area. So that might help you a little bit, but you ultimately need to look at a picture, and we'll attach a picture in our show notes. The one thing I'll mention is pattern recognition is really important. A high level 2 node that's P16 positive screams oropharynx. So if you have an upper lymph node that's closer to the base of the jaw and it's P16 positive, that's very likely oropharynx. That just should clue you in a little bit.
So listeners, as we mentioned, this is going to be much easier to understand if you look at the show notes or just pull up on Google TNM staging, because it's going to be hard to memorize from what we're saying. But I do want to highlight a few practical points to keep in mind that may help you remember. So first, for T staging. So for oral cavity advanced, that is defined as depth of the tumor through bone of local structures or invasion of skin, maxillary sinus, or the skull base. We define oropharynx advanced cancers if they invade the larynx, the pterygoid, or other structures in the head and neck location. And we define advanced larynx has invasion of thyroid cartilage that needs total laryngectomy over larynx preservation surgery.
So, Ronak, I think that's really important that you just highlighted what is locally advanced for T staging. And if you remember the concepts that Ronak said between each of these anatomical locations, that'll help you understand, because basically when we think about treatment of patients, locally advanced is different than patients who are not locally advanced. So I think that's really, really important what you just highlighted.
Yeah, and I think similarly, let me do the same thing for lymph nodes as well. Some key takeaways for our listeners to get. Number one, so for N1 staging, this is a single lymph node less than 3 centimeters. 3 centimeters, remember that, N1. N2 are multiple nodes or a node more than 3 centimeters but less than 6 centimeters. An N3 node is defined as any node greater than 6 centimeters or a node that has extranodal extension of the tumor tissue beyond the node. The important thing to also know about TNM staging for head and neck cancer is that stage 4 does not mean that there is distant mets and it can still be curable. The other thing I want to point out is that, again, this highlights why this HPV positivity is really, really important. So in HPV positive disease, there's actually a slightly different staging mechanism. There's no N3 because extranodal extension is not a risk factor, and end stage is determined solely on the number of positive nodes. And also, stage 4 disease in HPV positive disease is defined as distant metastatic disease, unlike the others. So listen to that again. Look at this at the same time that you're looking at the TNM staging. And these are the important highlights to remember when you approach your patients with head and neck cancer.
I think this is really important, and it's quite counterintuitive for the other tumors that we talk about. We always talk about how a stage 4 tumor, we think about that as metastatic, maybe not curable. And in head and neck cancers, there are some stage 4 tumors that are distant metastasis, and that would be an incurable setting. And that's why it's really important to look at the individual TNM portions of that and just to see, is this just simply a locally advanced tumor? And that's why we're calling it stage 4. Again, we're going to link all of the actual descriptions for the TNM staging in our notes. But to recap one more time, what is locally advanced for T staging for the oral cavity? It's invasion of other things around the area through the bone, the skin, maxillary sinus, or skull base. For oropharynx, it means that I've gone all the way to the larynx, the pterygoid, or other structures around the area, not just lymph nodes. And for larynx advance, you're invading the thyroid cartilage. So if you remember those just for general pearls, obviously it's more complicated than that. That's really what you need to know to help guide your treatment decision making.
That was a great overview, guys. Let's just bring it back to our patient. Let's kind of sort out where exactly we landed with that. He ended up having an exam under anesthesia and did get that bilateral tonsillectomy. And that showed a P16 positive squamous cell carcinoma of the right tonsil. His PET scan confirmed that, again, it was just that right level 2 node, no distant disease. We've got a guy with a P16 positive oropharyngeal squamous cell carcinoma, small primary with a single sub 3 centimeter ipsilateral node. That categorizes him as favorable early stage disease in the HPV positive categorization staging system. This is a patient that we should cure. We should expect to cure this guy. That is a setup for what we're going to talk about next time, which is with a disease that's favorable, how much treatment do we actually need to give him? And can we de-escalate without messing with our cure rates? Because right now it's a very curable cancer and we just need to figure out what's the least treatment we can get away with.
So for everybody, remember that head and neck cancer covers many different anatomical regions. Identifying the primary site of tumor based on the anatomical region is critical for prognostication and treatment planning. We think about head and neck cancer as driven by two common things. Carcinogen driven, we think about the tobacco and alcohol use patients, and that's often a worse prognosis. And then we have the viral associated cancers. We've talked a lot about how HPV-associated oropharyngeal cancer has a better prognosis, can occur in younger patients who are non-smokers. And just remember that there's also that EBV-associated nasopharyngeal carcinoma. The mechanism behind HPV we talked about today, and just remember that it's P16 overexpression. P16 on IHC is one of the things that you're looking for these types of HPV-associated tumors. For the workup, remember we have a direct visualization with our ENT surgeons where they do a scope to look for a primary, and FNA of a lymph node that's palpable on exam or FNA of potentially a lesion found on that scope is how we diagnose these cancers. This is a solid tumor. You don't need a core biopsy or an excisional biopsy like you would in a lymphoma that we've talked about in our previous series. For staging, a CT neck and chest is important. Remember, for the chest, we're either looking for distant metastatic disease or possibly a second primary lung cancer, particularly for those who have been smokers. Sometimes we find 2 separate primary cancers in one patient. When it comes to radiation planning, it's really important to get a PET CT, and so many of these patients will get a PET CT as part of their staging workup. When you're thinking about a patient who might go through radiation, many of these patients will, dental evaluation, swallow study, and smoking cessation are critical. Lastly, remember that staging can be complicated. It varies based on the anatomical location, but keep in mind what's defined as locally advanced, because that will change how you manage these patients. And we talked a little bit about the end staging. This will make a lot more sense in our next episode where we really talk about management of these patients. But just remember that when we think about N3 disease, that's extranodal extension, node greater than 6 centimeters. That's going to be the highest risk scenario. If you have multiple nodes involved, it's N2. N2 for multiple. I've got more than one lymph node involved. That's 2 nodes or more involved. That's N2, or a node that's bigger, between 3 to 6 centimeters.
Fantastic wrap up, guys. We really set the stage here for our discussion on head and neck cancer. So listeners, go back, listen again, take a look at our show notes, try to put all this in context. This will set us up for a fantastic discussion in the episodes to come. So until next time, we'll see you all later.
See you later.
Peace.
This podcast was edited by Resonate Recordings.